The pericardial effusion is drained, but the catheter is stuck. Percutaneous evacuation of pericardial effusion complicated by pigtail catheter entrapment in fibrinous pericarditis. Although pericardiocentesis has been demonstrated to be a safe and valuable tool in the treatment of patients with moderate to large pericardial effusions or cardiac tamponade, major complications might occur including death, cardiac arrest, and iatrogenic perforation of the heart or vascular structures. In this issue of the JCVA, the authors reported a 58-year-old female presented to the emergency department with complaints of dizziness and low blood pressure. Her past medical history was significant for Hodgkin's lymphoma status post-radiation, breast cancer, hypertension, and hypothyroidism. The patient had been seen in the emergency department at an outside hospital 11 days earlier for chest pain. At that time, she was negative for COVID-19 and influenza A and B, an electrocardiogram and high-sensitivity troponin were normal, and the computed tomography scan of the chest described no evidence of pulmonary embolism, pericardial effusion, or pneumonia. She was discharged from the emergency department the next morning. On this admission, the patient reported feeling dizzy and short of breath. The previous day she noted hypotension with a blood pressure of 58/30 mmHg. She was febrile on initial presentation and pertinent labs showed a white blood cell count of 13.2 Kelvin UL and high-sensitivity troponin of 7 AL. A transthoracic echocardiogram revealed a left ventricular ejection fraction of 70% and a large circumferential pericardial effusion with right atrial collapse in late diastole and greater than 25% change in mitral valve inflow velocities during the respiratory cycle, suggestive of pericardial tamponade. The patient was taken for emergent pericardiocentesis. The procedure was performed without complication using a subxiphoid approach on both TTE and fluoroscopic guidance. A bubble study confirmed proper placement of the 6 French catheter within the pericardium. And 350 milliliters of serosanguinous fluid was removed from the pericardial space and sent for further analysis. A post-procedure TTE showed near resolution of the pericardial effusion. The patient was taken to the coronary care unit for monitoring and started on oral colchicine. The patient's clinical symptoms, vital signs, and laboratory markers improved significantly over the course of the next 48 hours. She had minimal serosanguinous drainage, less than 20 milliliters 12 hours from the pericardial drain, and the decision was made by the cardiology team to remove the pericardial drain 44 hours post-placement. Attempts to remove the drain at the bedside were unsuccessful due to significant resistance when applying traction to the catheter. Removal was subsequently attempted under fluoroscopic guidance without success. The cardiothoracic surgical team was then consulted to remove the drain surgically to avoid injury to the heart or fracturing of the catheter. During the surgical procedure, transesophageal echocardiography was performed to rule out intracardiac migration and to attempt to visualize the course of the catheter. Upon opening the pericardium, the surgeon noted extensive fibrinous and exudative adhesions between the pericardium and the heart. Even after blunt dissection of the adhesions and additional chest retraction, the surgeon was unable to visualize the course of the catheter. A small portion of the catheter was visualized near the right ventricle. But even small manipulations of the heart or catheter led to significant hemodynamic instability. The patient was placed on cardiopulmonary bypass to facilitate additional dissection of adhesions and removal of the catheter. The visible portion of the catheter inside the pericardium was transected and the wire was advanced through the catheter. This segment of catheter was presumed to be the proximal segment of catheter entering the pericardium, but the wire emerged from the catheter only after advancing it a significant length. It was evident that the visible portion of the catheter was, in fact, a distal portion of the catheter emerging from beneath the heart, and that the proximal portion of the catheter was still unseen. Upon further dissection, the catheter was visualized entering the pericardium near the right ventricle and passing anteriorly along the left anterior descending artery toward the base of the heart through dense fibrinous and exudative inflammatory tissue. From here, it wrapped posteriorly around the heart and left atrium. Gentle traction on the catheter still did not free the catheter, and only after the catheter was dissected from the inflammatory tissue on the anterior portion of the heart was it freed completely. The inflammatory tissue was sent for pathologic analysis. The patient was weaned from cardiopulmonary bypass without issue and taken to the surgical intensive care unit. The patient was discharged to inpatient rehabilitation on postoperative day 7. Tissue pathology showed benign epicardial tissue showing acute and chronic inflammation. The pericardial fluid was suggestive of a viral etiology. It was noted to have 3+ white blood cells with predominantly lymphocytes. No organisms were seen on culture and the fluid was noted to be negative for malignant cells. In conclusion, cardiothoracic anesthesiologists, interventional cardiologists, and cardiothoracic surgeons should be aware of this potentially life-threatening complication of pericardiocentesis. A team-based approach with imaging should be used in situations where the catheter is not easily removed.